Okay, so last time we left off on the STDs, STIs section. The PDF I gave you guys came with another chart here to have it all kind of in one place. Mm-mm-mm. Yeah, so had everything in one place, and we're just kind of gonna talk through everything that's listed here, see if you guys have any questions on anything. As well as talk about pap smear education. I kind of just have it written down, and then go through the reproductive disorders, the main ones they really go over: PID, toxic shock syndrome, a little bit about endometriosis, the leiomyomas, cervical cancer, endometrial cancer, and then talk about hysterectomy at the end. Okay. Okay, so first, I kind of have it split up into the uncurable ones, uncurable STDs, and then the last three are all of the curable ones. So first one, we're gonna do genital herpes. So the genital herpes, we know it's being caused by the herpes simplex virus, either one or two. Not really, don't really need to be like super specific on specifically like what viruses, like what specific virus, just like the general basic, like herpes simplex virus causes herpes. That makes sense. Um, that's really all you have to know about it. Here, I guess the mode of transport is there just to give a little bit more context, but again, not something I think needs to be heavily um, focused on, just kind of like something to know or something to have there, just to have there. Don't have to memorize it, I don't believe. The main thing we're going to focus on is probably the manifestations, your interventions, and your education more than anything else. So with your genital herpes, your thing you're gonna have is really bad burning pain, itching, tingling, as well as blisters, and it can come with a fever as well. So fever, malaise, which is that feeling of just feeling bad. So that type of, so I guess I'll put here fever and malaise. And the itching and the tingling happen about 1 to 2 days before outbreak. Just make it a little more clear there. Okay, so again, herpes, main thing you'll see is that burning pain in the area. So another thing I think could be important here to write down would be that it is extremely infectious. Um, Even when not experiencing symptoms, because someone could be having a recurrence of herpes even without actually showing any symptoms. So they could be asymptomatic, but still having viral shedding. So obviously, someone that is having the symptoms, having the little blisters that you would expect with genital herpes, you are going to want to avoid sexual contact because you could end up giving the disease to your partner. But even without having the active symptoms, there's a possibility that you could still be contagious just because you could be having viral shedding but be asymptomatic. So kind of like some people were asymptomatic with COVID, but were still able to transmit it to other people. Okay, so that's something to keep in mind. And it kind of goes also with the education. Something else that I'll write down here is that recurrences can happen due to stress. So anything that can include like lack of sleep, another infection. So kind of think a almost similar to like your sickle cell triggers. A lot of these like autoimmune triggers. This is not to say this is an autoimmune. I'm just saying like think about all like the stress triggers that affect other diseases that we've talked about in the past, um like your sickle cell and all that other stuff. All of these stress triggers, pretty much the similar stuff that can cause it. So just some examples of things that could cause stress and cause it to act out. Okay. So your main management here. So there's some diagnostics here. For now, I'm just gonna talk mostly about the important stuff. Obviously, you can have cultures and all this other stuff. Probably the only thing about diagnostics that I would keep in mind more than anything would be that you can have false negatives if you test too quickly, which makes sense. You're not always gonna have it's always not always gonna be detectable immediately. So you can have false negatives if the testing happens too quickly. So your medications that are used to treat the medication, and again, this is an incurable one, so you're just treating symptoms, are your cyclovir. So all the ones that end in cyclovir. So acyclovir, valacyclovir. So the acyclovirs, and in general, the cyclovirs are a type of class that are antiviral. So when you see cyclovir, just think like antiviral. And it also promotes, you could say promotes healing. Okay. So then for education, yeah, another mention of we're kind of keeping away from some of the stresses. Um, again, that there can be viral shedding even without any lesions. Some of the side effects of the meds include nausea, vomiting, GI upset. You want to take the medications as soon as possible when you start having symptoms, or at least within 72 hours of, of your outbreak. Try to avoid sex when lesions are present, especially when lesions are present. And some things that might be good for your comfort could be cold or heat therapy, depending on, I guess, the person. Okay. And again, I've been posting a lot of pictures. Are you guys okay with me posting a picture of what they look like, or would you rather not? Jennifer, can the med be taken with or without food? Let me do some, because it does cause nausea, vomiting, and GI upset. Here, I'll go do that. Look it up for you. You guys can answer if you guys want pictures of the diseases, or you can look it up on your own. I don't know. Um, so let's see. So I guess I'll add that in education there. So what I look, Sebastian wants the pictures. Okay. So the medication can be taken with or without food. For some people, taking it with food can be done to reduce the GI symptoms. So yeah. And Sebastian wants the pictures. No one else said otherwise, so here you go. I'll add another row below. Here, pictures. See how that looks. It's I guess you'd have to zoom in a little bit on that. Maybe I can make the rows a little bit bigger. Yeah, it's probably fine. Is there any way for me to make it bigger? Okay, I guess that's visible to some degree. Okay. Any questions on genital herpes? Okay. So on to the next incurable. one. So genital warts, and this one, you're gonna want to know that it comes from, so I guess I'll specify. So herpes simplex, and you don't have to know the specifics, just if you see HSV, herpes simplex virus, you know what that's referring to. This one's caused by the human HPV, otherwise known as the human papilloma virus. Papilloma virus. So that's your HPV. That's as far as you really need to know about the name or anything specific. There's like an alternative name for it, but you don't really have to know that. Something to keep in mind is that this is a big risk factor for cervical cancer. So your genital warts can cause cancers, but especially your cervical cancer. So I think that's probably the most important thing about it. I'll just both these parts here. So again, here we don't have to focus too much on the mode of transport, but it's there if you guys want it. So the main manifestations is that it's kind of like a cauliflower-like mass. It's probably this one's a little bit easier if I just show you the picture right away. See how that, ooh, that doesn't look too good. I think I'll delete this row and just post it underneath instead. So genital herpes, get through the picture. So that's a little bit more genital warts. Right here. So this is what they mean by cauliflower little warts. That's kind of what they're referring to. Little white masses, clear kind of white masses. Okay. They can bleed if they're disturbed, meaning like if you touch them too much, friction, all that stuff. But it is typically painless, but itchy. So typically it is painless. Okay. There's some of the diagnostics that can be done, but again, the main focus for now is going to be on the intervention. So the things that can be done for them include laser therapy. You're going to literally laser them off. Cryotherapy, meaning it's basically um, iced off for like applied ice to the point where it kind of dies off. TCA or BCA, which I believe is related to acid. So that is you're literally going to burn it off with acid. Put acid here just to make it a little bit easier. And conization, which is essentially exciting it off. Okay, let's add topical if it's mild. Yeah. So this, which is removal of lesion from the cervix. Okay. So another big focus is again on your education. So here's some examples, like the acid treatment can be given weekly in the office. Cryotherapy can be done every 1 to 2 weeks until they're gone. Laser therapy, if they're very extensive and bad, like a bad case of it, you want to make sure to use condoms to not infect someone else. Pap smears, because remember, this is going to be an important one, because remember, it is one of your number one causes for cervical cancer. So pap smears are going to be good as a secondary prevention method, a screening to try to catch it. Avoid sex until lesions are healed, because again, that's another point where we can become infectious for others. And more education on getting the HPV vaccine to prevent infection in the first place. And here's some more information about HPV vaccine. So it can be done to prevent infection. Most effective if given before sexually active. It's pretty effective. Can be given through this age range, but it's especially recommended in the ages from 9 to 26. Another thing to keep in mind is that a lot of the time, chlamydia, gonorrhea tend to coexist with genital warts. So someone that is being tested for warts will also get tested for chlamydia and gonorrhea. Those are the two besties. They kind of go with each other a lot of the time. And since we were talking about pap smears, I'll just quickly go through the some of the pap smear education. So your pap smear is one of your tests for cervical cancer. Some of the things that want to be avoided before 24 hours before the test, you want to avoid sex, douching, any vaginal medications or deodorants before the test because that can throw off the results. Specifically, it's used to detect precancerous or cancerous cells in the cervix. And it can be an annual screening for women from the ages of 21 to 65. And you also want to make sure to do it after menstruation so that the flow does not interfere with results. Okay, so having it all in one place hopefully is helpful. Is there any question on what we just talked about here? Your two incurable diseases. So we can treat their symptoms. We're not really going to be treating the disease. It's there with you. Okie dokie. So then we can start learning a bit more about chlamydia and gonorrhea. These are your two besties. Chlamydia in particular is your most common STD caused by this virus that whatever. I think it's the C stands for chlamydia, I'm pretty sure. So chlamydia, trachomatis, and your gonorrhea, which is caused by this bacteria here. If you see the names, you'll know which one it is because it's kind of in the pathogen's name already, the name of the disease. Your mode of transport's usually through sex. Probably the only thing worth keeping in mind is probably this one here for chlamydia. It can be transmitted to the newborn, and this is something that you'll learn more about in your OB class. Um, yeah, I believe your gonorrhea can also be transmitted through to the baby. And I'm gonna look this up actually. One of the two can cause kind of like an eye infection in the baby. But I'll add it in later. It's not something that's too heavily emphasized here. It's more so for your OB. I'll just do the dashes. Okay. Your manifestation for both your chlamydia and gonorrhea are going to be pretty similar. They're going to be mainly asymptomatic. But if they do have symptoms, then with chlamydia, you have that yellow discharge, change in urinary frequency, some abdominal pain, and then another key thing is that it can cause PID, which we'll talk about a little bit more down the line, I believe. And if I don't have it, okay, cool, I do have it. Okay. And then back to gonorrhea. Gonorrhea can have redness or swelling first. It also kind of comes with a yellow, maybe yellow greenish, smelly discharge, pain when you pee, and possible PID as well. And what's another thing? I think it is gonorrhea that can have. So for men with gonorrhea, they can have like a penile like drip, like a just this like it's called like the drip. They have the drip, not in the good way, but they'll have like discharge coming out. So they might not have any other physical symptoms other than that discharge. Okay. Um, just make sure I have everything in line here. Yeah, so it is gonorrhea that can cause, this can also be transmitted to the newborn. So they can have eye infection from a mother that has gonorrhea. And let's look that one up actually. So that's kind of what this looks like. So something that you guys might get to do if you get to be at the hospital for OB is you can give the child like this little eye ointment to try to prevent the possibility that they get gonorrhea infection in the eyes. Even if the mom isn't doesn't have gonorrhea, it's just something that they do for the babies. So that's alongside, I believe it's they get like a shot, um, and you'll give that in the thigh. So that's something you might actually get to do in clinical. So yeah, let me just remind myself exactly what the shot is. Yeah, and then also chlamydia can cause a similar kind of eye infection. So that eye ointment kind of helps with both. And yeah, it is vitamin K. Yeah. So you also might give them a vitamin K injection in their thigh. So we call that like the eyes and thighs. And that's something you guys might get to do. That's pretty cool. Um, yeah, depending on where you are, that might be the first time you guys get to do an injection pulling from an ampule. So some places they have the vitamin K in an ampule, and you have to actually pop the ampule, use your filter needle to get it out, and give the child the vitamin K injection. And then some places, like at Kaiser, they have it pre-filled. So when I did it at Kaiser, it was pre-filled, and I just kind of went for it. Okay. Any questions so far on anything? Because we are tackling two at the same time. They're very similar, and they're usually paired together. So that's kind of why I'm trying to do them both at once. And they're usually treated together and assessed for together. Seems like we are good. Okay. Some of the diagnostics here. I think the main thing to really think about is the fact that, again, these are the two besties. They always go together. So if someone has one, you're going to test for the other. And then they both also have a heavy association with your genital warts. So if someone has genital warts, they're also going to be tested for chlamydia and gonorrhea. And so some of the medications here, azithromycin, your Synthromax, that's going to be, whoops, it's going to be your med. It's going to cover both of them together. So this is the med that's going to be covering both of them at once. And then for gonorrhea by itself, the ceftriaxone is the most effective one. And then for chlamydia, your doxycycline is another one that can be given. So both of these listed here. And actually, your azithromycin is the ointment that you give to the baby, to the newborn. It's a azithromycin ointment, but in this case, they're getting it PO because there's no baby there. It's just the mom. So I think possibly just no azithromycin. Keep this one probably in mind a lot, and then just probably just main thing would be azithromycin and recognize that these are not viral diseases, so they don't have the cyclovirs. The cyclovirs go to the herpes one. Okay. So the education is again pretty similar. So there is the risk of infertility slash sterility because they can both cause PID. You should treat, if you have one, you should treat for the other. Patient, you should, after you have it, you should be informing all your partners. So this should be included here too. And obviously, you don't want to have sex until the treatment is done, because otherwise you can get a reinfection. So you might see Kaplan questions or questions on like a test where it's like, let's see what kind of question it would be. It'd be kind of like, um, I think questions just like on reinfection, either the patient didn't finish their treatment and got someone else infected, or just you educating them on like maybe they think, okay, I took my medication, my one-time PO med, and now I'm gonna go back to having sex with my partners or whatever. Just like educating them that until your treatment is completely done, you're not gonna you're gonna avoid that. You're gonna make sure you inform all your partners so they can get themselves checked out as well. Yeah, and then again, the PID risk is another just a key part of it. Okay. And now you guys are gonna get some pictures. This one was what? Um, chlamydia. Chlamydia is also known as, is it chlamydia that's known as the clap? I think it's actually gonorrhea. Gonorrhea is known as the clap. Mm, let's get you some pictures. I think for these two, I actually have like a little mini chart thing rather than pictures. So here's kind of just like a quick one. Gonorrhea. Still doesn't want to fit in there. Yeah, there we go. Okay, so hopefully that's gonna be helpful. And then lastly, we're going to talk about syphilis, which is another curable one, but it's got a lot of steps to it. It's got a lot of things going on with it. Any questions on anything so far? Okay, cool. And then, so with syphilis, this is the causative agent, but again, probably not the biggest focus on that. Some modes of transport, again, probably just knowing the manifestations is a bit more important for this. So your syphilis has a few stages. Your stage one is defined by a painless, that's bolded fully, canker sore. The lesion will typically go away after 3 to 6 weeks. And this will happen at the site of entry. So wherever the bacteria made its way in, it is going to have that painless sore. So it might not get treated because the lesion was not painful. People might be like, oh, I don't know what happened there, but it doesn't hurt. So I guess I'm okay. Or they might not even notice it potentially because, again, it doesn't hurt. So, but it is highly contagious. So, after that time passes, you have the secondary stage, which can happen multiple weeks or months after first exposure, so your primary. So this can happen 6 weeks to 6 months, basically just multiple months potentially after your canker sore went away. Comes with flu-like symptoms, so fever, feeling bad, body aches, all of that stuff there. And the main thing that defines the secondary stage is the rash. So you'll have this whole rash on the palms, soles of feet. You can even be just like full body rash, to be honest. It's like a full body rash, but especially on the hands and palms of feet, like a body rash. So after you have this reaction, this is when people are more likely to go ahead and get checked out. And again, it's still possible with treatment, but it will go away on its own. Um, will go away on its own and become late. And then when it is latent, it means it's kind of in hiding. It's not really active, and you don't have any symptoms, but it's still just kind of chilling in there. And so it's highly contagious. And yeah, that's probably the main thing you want to know about it. So when you have your latency stage, you have no signs and symptoms, and at some point, and this can happen multiple years um, after your first contact, multiple years, it can lay dormant. And when it becomes stage 3, that's when it starts having an effect on internal organs. Um, and there's a few where it's very particular for. So there's the cardiac syphilis, where it's going to particularly affect and damage the heart, leading to kind of heart failure-like symptoms. Neurosyphilis that can affect the brain, cause meningitis. And then gummas are some kind of tumor-like growths of the tissues, and it can occur all over the body and stuff like that. So I'll kind of give a picture here for syphilis. And it kind of has the stages here. So here we see the stage 1. It's going to be a painless sore, whatever the zone is. So you can see here, they kind of highlighted the mouth area and the groin area. The body rash on stage 2. And then after that, in between stage 2 and 3, it can lay dormant for years until suddenly stage 3, it starts to affect vital organs. So here they specifically mark up the brain, the heart, your liver, and your bones. Some things that it can affect. But here for class, they just kind of talked about your cardiac one and your neuro. Some diagnostics here. But the main thing what to keep in mind is the treatment is with penicillin G. And if someone is allergic to penicillin, then they can take a different type of med. I believe it is I think you guys had a question on it, but let's see, tetracycline if they're allergic. PCN is penicillin. Okay. So some education that you can give for the patient is it's transferable to the child. It can cross the placenta. Um, if you are having any fevers and chills, you can take Tylenol or NSAIDs. Uh, the penicillin can cause some sort of reaction that leads to you having kind of like a rash, kind of like a achy rash reaction. So they say that if the medication is making you have these fever chills and some other type of reaction, then you can take Tylenol and ibuprofen. Mentioned here again, if you're allergic to penicillin G, tetracycline. You want to practice safe sex with condoms, and you might have the possibility of needing to be retreated because again, well, it's just once curable, but again, it can come back, or you can get it again, basically. Okay, so that's syphilis. I'll throw you guys in a picture of a gumma. So right here, that's what that looks like. So you can have this throughout the body. So do we need to know which ones are reported to the CDC? Mm, I can't confidently say yes or no to that. Um, but just in case, I will just let you guys, I'll just write it down for you guys. So let me see here. I'll probably keep it at the top somewhere, like right here. So I will give this to you guys here. So the reportable ones are chlamydia, gonorrhea, syphilis, wrote here chancroid, but genital ulcers, HIV, and AIDS. So ones that are not out of all of these, let's see which ones that are herpes doesn't have to be reported. Uh, uh, um, yeah, I guess just herpes. Let me double check if chancroids was referring to the wart, genital warts. Yeah, not your genital warts. So I don't want to confuse you by having that's just extra info there. Yeah, so these are the ones that have to be reported. And I didn't go too much over HIV and AIDS. I don't think it was very heavily focused on for this class. But in 240, we actually have for this actual week we had HIV. So I don't think the focus in this class is too much on that. I think it was just a passing by little small section on it. Okay, so that's the whole chart. You guys have any questions on anything else? Okay, so then when we're going on to reproductive disorders, this is where a little bit more um, participation is needed now, because we already had a completed chart, so I didn't want to have to ask for every little thing. But for this one, it should be a little bit more participation for this one. So your pelvic inflammatory disease, your PID, what are some of the risk factors for it? We actually talked about a few of them. Yeah, gonorrhea. Yeah, the two besties right here. Anything else that you think could be risk factors for PID, PID, PID? Kind of maybe some that goes with getting STDs, kind of like a general, someone that gets STDs a lot probably has a lot of, yeah, multiple partners, unprotected sex, obviously. So it kind of goes with the whole STD. So a lot of the PID stuff comes from STDs a lot of the time. So it's douches. I believe so. So douching. In general, I feel like douching is like a risk factor for like everything in here. So I think it's like, oh, seems to always be the case. I'm like, so when do you want to do that? Or maybe just don't. Then another one I'll throw in here is um younger than 20. Younger than 20 years old is another risk factor. And the reason for that is kind of due to just people who are younger than 20 year olds statistically have a higher risk of like getting STIs. Yeah, pretty much. Okay, so what are some of your signs and symptoms? Yeah. And then again, you don't have to hard commit to memory your risk factors for this. It's just kind of like if you see it on the as a if it ends up being like a saddle or something, as long as you're able to be like, oh, I remember that and click it, then you're good to go. You don't have to there's no I highly doubt they'll give you guys like an open answer one where it's like type in every risk factor. So you don't have to bring it out just from your brain cells. You can just be from the multiple choice. Yeah, so your lower abdominal pain for sure makes sense with where the area is going there. Yeah, for sure you're gonna have abnormal vaginal discharge, and it's like a yellow greenish kind of thing. Seems to be common thing. A lot of these abnormal discharge come out little kind of come out like that. Yeah, fevers and chill, kind of like flu-like symptoms. And I'll add in kind of tenderness. So well, it kind of goes with the lower abdominal pain. So I'll probably just kind of keep them together here. Um, and just write down that some women can be asymptomatic on it. Okay, so what are your complications? Let's probably think of like like the main one. So if not treated, ectopic pregnancy is for sure one of them. Yeah, infertility is, I think, the main one to think about for this. That's kind of the thing. Again, when we were talking about gonorrhea, chlamydia, we kept bringing up it can cause PID, which can lead to infertility. So it comes up a few times. So that's the main thing to think about there. There's a few other things that you guys went over, but I don't think it was as much of a focus. I think your infertility is probably your main one. So then what could be some management for your PID? Yeah, some antibiotics. Spell that one wrong. Boop, boop, boop. Just in case they asked. Oh, it's specifically doxycycline, 100 milligram PO. Poo. PO. Yep. So pain management. So your pain management with analgesics, heating pads, and I'll add in a sitz bath as well. Perfect. I was looking for that. You brought that out without any prompting, so good job on that. So semi-Fowlers can promote drainage. That's pretty much it for that. So your doxycycline, I believe for when you're looking back at the chlamydia and gonorrhea, it shows up again on chlamydia. So that could be a way to kind of cluster them together. So with the besties, you can think about azithromycin and then your PID and your chlamydia with your doxycycline. If it ends up being asked, I always just err on the safe side, especially because Miss Orozco does the farm class. Sometimes she just likes to bust out some farm stuff. But okay. Do I have any pictures for this one? I think just one for context. So here you can see the fact that it's an inflammatory disease. So you're going to see inflammation of the fallopian tube, inflammation of the ovary, inflammation of the uterus, and you can see how the or I guess it's her left side. Her left side looks compared to her right side. Okay. So moving on to the toxic shock syndrome. So the origin. This is kind of like the bacteria that causes it. Or a rat, or even the bacteria, like where does that bacteria come from? Like what is like one of your big things that it's associated with? Usage of something. Yeah. So, yep, it's associated heavily with um, improper tampon usage and due to Staph aureus, right here, Staphylococcus aureus, Staphylococcus aureus, which is bacteria people often have in their like on top of their skin, kind of going around. But yeah, it's heavily associated with tampon usage. Okay, so what are some signs and symptoms you guys can remember? For sure, some vomiting and some diarrhea. So, so we have vomiting, diarrhea, pain, fever, malaise. So we can kind of cluster that all into like flu-like symptoms. So it's an easier way to think about it. Don't have to remember multiple different ones. We can just think of just flu-like symptoms, which is nice. Some sore throat even, weakness, aching. Yeah. So, and I would say that one is in particular in the first 24 hours. What else can you guys associate it with the toxic shock syndrome? Not so much hypovolemic, but you're getting septic shock. So remember, it's caused by your staph. So it's called shock syndrome because it does have the high risk of shock, and it's caused by this bacteria. So instead of hypovolemic shock, you won't think of septic shock. So you'll and also throw in you have like a general rash, and you will have hypotension leading to syncope, aka like fainting and septic shock. But a lot of that comes with vasodilation, your severe hypotension, third spacing, um, all this other stuff that you will learn specifically septic shock later. I know you guys in 220 kind of said septic shock exists. and you guys just focused on hypovolemic, you'll focus on septic shock later and 240, which is actually what us in 240 actually had our test for that on Thursday. This last Thursday we had it on that. Okay. So if we mentioned that, what's your management for this, I guess? I won't give you guys I was gonna give you guys a hint, but I'll just keep to myself and see how long it takes for it to be mentioned. So what is your management? Yeah, IV fluids for sure, antibiotics for sure, and just in case they ask, it's specifically penicillin, or even like a vancomycin. For sure gonna monitor vital signs. Kind of goes along with the fact that they can get um, shock and stuff, septic shock. Looks like you guys even having your PowerPoint that you can have decreased platelets. Yeah, so I'll kind of just go with the IC. I'll include that just as a fun little tidbit on septic shock. Septic shock can have DIC. So if you guys remember, that's your microclots and your bleeding risk. So that's why blood transfusion can be in management because person could be losing, could be bleeding from DIC. They might need platelet transfusions, not platelet transfusions, sorry, fresh frozen plasma. So they might get some blood, fresh frozen plasma if they have DIC because of the septic shock. But I think for 220, your main focus is probably on these two for now. Steroids, yeah, that's one of them. So we mentioned that septic shock. So septic shock, another thing about septic shock is you have it's a severe inflammatory response. So we remember that corticosteroids are used for inflammation, so it makes sense here. So I think for now, you guys didn't really know too much you don't know too much about septic shock. So you guys were just kind of told the management of these things. So a little bit more context on why these two are being given. Called like SIRS. So that's your systemic inflammatory response. I don't know what the syndrome, I think it is. And you guys will learn again, you'll learn more about that later, but I just wanted to provide a little bit more context on why these were mentioned in your PowerPoint. So I think it helps some people that need to know the reasons for why on everything. And then there's one more, and it kind of has to do with like let's say this person is coming into the ER or something. Um, what is the first thing you would do? Again, we said that this is associated with like kind of like an infection due to tampon usage. So what would be like your first thing to do? Okay, that I think the education can come later after we treat them, but it's definitely a good thing. So that's definitely something we're gonna use. Yeah, that's what I was looking for. So basically, you want to remove the tampon. You want to remove the source of infection. First thing you always want to do there. So similar to how when someone has, let's say someone has an infection from their IV site, the first thing you would do would be to get rid of it. You want to get rid of the thing that's caused. You want to get rid of the source of the infection. You want to get rid of that. You want to DC that IV. So similar idea here. You want to remove the tampon because that's the source of infection. And then Alexis mentioned education on the use of tampons. So how often should they be changed? According to the book, I don't actually know what people actually do with it. Just going off of the PowerPoint in the book. So according to Iggy, there's a specific one. Yeah, it's 3 to 6 hours. As for what people actually do in real life, I don't know. But yeah, that's kind of what's written in the book. Yes. So wash hands before, after, or before insertion and after removal, or before removal, before insertion, removal. Yep. And then an extra one I'll throw in is possibly use pads instead of tampons at night. So I think the thing with the tampons is that because it's inside, if there's any bacterial stuff going on there, it's basically in um, in the place that could cause the most harm because it's inside instead of at least with the pads or just on the outside. Okay, so good job on that. Yeah, and then I'll give you guys a picture. I think I don't know if this was in your guys' notes, but I like this picture. I like the pictures when these type of pictures when they come up because I feel like they help me remember the thing just because I remember the picture. Yeah. So I like hopefully the pictures help a lot. You can see how big this outline is now just because of the pictures and the charts. Hopefully you guys are getting good use of the charts as well. Hopefully that's helpful. Feel like when in 220 there's so much content that I think I needed pictures and charts to help me. So hopefully that helps. It does make the outline pretty big, but hopefully it's still more concise than what the current material actually is. Because that's kind of the goal of the outlines is just to kind of have more concise stuff down because of how much information you guys are being put through at once. Alrighty. So what about endometriosis? So this is just kind of like asking, what is it exactly, or roughly? For this one, I'll just get immediately to posting this. And then the picture, I'm sure, can help you wait, figure out what it is. So right now I'm just looking for kind of like an easy way to think about, like a shorthand way to describe what it is. Lesions and cysts, yeah. So this is in fact not caviar on top of all this tissue. It's little cysts, and they call them chocolate cysts. I think it looks more like caviar, but that's kind of how it can be defined through text. Ooh, yeah, I'm sure that sucks a lot, especially once we go over the some of the signs and symptoms. Oh, I'm sorry to hear that. So these are at least specifically, I guess, cyst, chocolate cyst, grow inside the uterine cavity. Yeah, I'm sure. I'm sure you can. I guess some of the signs and symptoms. So this is this condition here. Yep. So one of them is painful intercourse. Yeah, pain during menstruation. Yep, lower abdominal pain. And just in case, I think I remember at some point I was doing questions and I saw this word right here. That's the name of painful intercourse, just in case. Just in case you guys will be exposed to that word, in case that's the word they choose to use. Bladder, um, bladder and bowel. Yeah, so it can cause rectal pressure. So that kind of goes with that. Yep, it can cause backache as well. Kind of goes with that lower abdominal pain as well. So lower abdominal and back pain. And then a few of the other ones I have is that it could cause some discharge. And this one's defined as brown, black, or even pink, and can cause infertility. Depends on how it's progressing and stuff. So I guess another thing is bleeding is usually present. Just write that out, and I'll include sex those that are 20 to 30 years old, and is especially common with those whose mothers had a history. So it is kind of has that some of that genetic thing going on, so can be passed down. So if mother had endometriosis, more likely that you will have endometriosis as well. Okay, so what about the management for it? Yep, the NSAIDs is going to be your biggest one there because not only does it help with the pain, remember we talked before, it inhibits prostaglandins, which is your kind of like your general inflammation, one of your general inflammation hormones. Oop. Yes, so Kayla talked about the hormonal therapy. Oop. Suppress ovulation, so that's your oral contraceptives. Yeah, which is typically like your estrogen and stuff. And what about a surgery? Is there any surgeries you can do for it? A laparoscopic, I mean like a laparoscopic hysterectomy or something? Yeah, you can do, yeah, I guess like a laparoscopic surgery. So meaning they're gonna go in and see if there's anything there. If there is, they remove it. Yep, laser therapy. And then lastly, if everything else fails, this is another type of surgery that could be done. Total AH. Not sure what the A is, but I'm sure the A is for hysterectomy. Okay, and then that's something we'll talk about down here. Okay, so let's I want to go back here just to see what else we've talked about here. So this one, your PID, we know it comes from STDs. So that's going to be coming from some of your risk factors, lower abdominal pain, because that's where the infection is, discharge, flu-like symptoms. cause infertility, treated with antibiotics because it comes from STDs, which are infections. Toxic shock syndrome, another infection. So again, it's treated with antibiotics. You want to remove the source of the infection. It has the word shock in the name, so think about shock. Even just knowing the hypovolemic shock gives you still like a large amount of the picture for toxic shock syndrome. Total abdominal. Okay, that's what the A was. But yeah, just knowing the fact that it has shock should help you just kind of more or less know some of the stuff that's going on. So the hypotension stuff. So we're going to give IV fluids, and then I try to provide a little bit of context for septic shock. So that's why these two are included in your management. Talked about the prevention, and then the endometriosis, the NSAIDs. Similar to when we talked about the PMS and some of the other um, disorders, some of the other reproductive problem ones like PMS and yeah, dysmenorrhea and whatnot. Okay, I think this one's a little bit shorter, but this is uterine leiomyoma. So give you guys another picture. Kind of has it. The picture will spoil it, I guess. But yeah, this is uterine fibroids. These are benign fibroids, basically tumors, benign tumors in the uterus, and in and around the uterus, in and around the uterus. So as you can see here from the picture, you have these little fibroids, and we can tell that it's a tumor because it ends in oma, oma meaning uh like a growth, and leiomyo means smooth muscle. So it's a growth of smooth muscle in the uterus. Okay, let me see what else. So I'll write down it's unknown etiology, so it's not really known why it happens. Uh, Thought to be maybe because of estrogen stimulation. Intramural containing the. You don't need to know that actually. Just smooth muscle, just in case. All right, so what's some signs and symptoms of this one? Looking like this. Yeah, so this one's gonna have pelvic pressure. Makes sense because you're gonna have these growths there, so they're gonna apply some pressure. Constipation can be one. Yeah, so I think one of probably like your main stuff that you want to think about with these is some of your bleeding. So you can have split this up into menorrhagia, which is increased menstrual bleeding, and metrorrhagia, which is bleeding between menstrual periods. Just in case these words come up, you will have at least seen them once. But again, it could just be clustered into bleeding, uterine bleeding. Okay, what about your urination? And also, it can be asymptomatic. So we're having some pelvic pressure because of the growths. So how might it affect? Yeah, you can have It can either be increased urinary frequency or urinary retention. Awesome. And again, because we have bleeding, you might have decreased HNH due to bleeding. So that makes sense. All right, what about your management? So you guys mentioned total abdominal hysterectomy. You can do that, yeah, if it's like a large. Yeah, myomectomy is just kind of go in to remove the fibroids. And it can be done a few ways. Could be like a laparoscopic, open surgery and stuff. So kind of, I think if it's going to be a myomectomy, it's probably laparoscopic. The removal of fibroids by itself. So just kind of going in, removing the fibroids, and then because some people it might be really bad, it might just keep growing back. So at some point they're like, okay, we don't want to have to keep coming back in to remove the fibroids, so we can have a total abdominal hysterectomy or even a total vaginal hysterectomy. So they're going through different pathways. So either it's a large fibroid and we're removing them through incision in the abdomen or through the vagina, in which case it's like they're smaller fibroids. Try to, and we will kind of talk more, again more about all this stuff when we talk about hysterectomy. Okay, any questions on the two things we talked about so far? The endometriosis and your leiomyeloma, or leiomyoma rather. Okay, we're almost done here. Cervical cancer. Okay, include this little picture here. So you can see here, cervical cancer is gonna, of course, happen on the cervix. So we have this cancer tissue on the cervix. All right, so what are some risk factors for cervical cancer? Yep, your infection with HPV is a really big one. That's your number one risk factor for your cervical cancer. What else? Yeah, multiple births. So having multiple births. Yeah, HIV and AIDS can cause it as well. Multiple sex partners as well. Obesity is actually one of them, yes. Someone said family history, long term of oral contraceptives. Let me see. Let me double check on that one. Yeah, sex at a young age is one of them as well. So, and that one's, yes, sex younger than 18. And yeah, so Kayla's right on that. So long-term use of oral contraceptives. Yeah, pretty much. So I think this one's a big one to keep track of. This one kind of goes with a lot of them. And I think the ones I see a lot in questions is probably this one and this one I see a few times when I did questions. Okay. Okay. So what are some of the signs and symptoms of cervical cancer? Okay, so what do we got here? Pelvic pain, painless vaginal bleeding, bleeding after sex, weight loss. Yeah, so for me, I have it kind of split up into initially kind of like asymptomatic and limited to cervix. Eventually, metastasizes. I'm not good at spelling that word. Uh, to other public structures, and that's when it starts to lead to the painless vaginal bleeding. Yes, so that's when it's your leg pain is a late sign because that's when it's already metastasized to other parts, so it can spread through the lymph system. Ooh, that's when you have like a fistula. What would be the exact name of that fistula? Let's see. Probably like colon-vaginal fistula, maybe. I don't know what they would call it. Or rectovaginal. Okay. So here you would see that little fistula, so it connects straight to the where the vagina is. So then you would have feces. Yeah, that would cause a lot of issues. Yeah, so you would have feces coming out of the vagina in that situation. Yeah, so that's possible. So yeah, you can have rectovaginal fistulas. Actually, in 212, I think someone shared that they actually had a patient that had that's was actually what was happening with them. So feces coming out of the vagina, and obviously that's going to be a huge UTI risk, sepsis, huge UTI, septal like risk of sepsis, and whatnot. What are some diagnostics for this? Yeah, your pap smear is your number one, and remember we talked about it all the way up there, some of the guidelines for it. And then yeah, pap smear. So cryosurgery would be more of a like intervention at that point, but uh, just remember your gold standard is always what for cancer? I guess pap smear is similar-ish, but yeah, your cervical biopsy. It's always like your gold standard and whatnot. So then we can move on to just management, just like Anne mentioned. You can have cryosurgery, laser surgery, ablation, which is basically you can have like heat burning it, um, try to destroy it with heat or ice. You can even have like ice ablation, heat ablation. So that's something they could do to kind of just destroy the function of it, similar to your some people can have like a heart ablation. So if the heart's acting up, they can just kill that part of the heart. So that's something that's really cool. Yeah, so some of your surgery, you have the condensation biopsy as well as your LEEP. So that is your loop electrosurgical excision procedure. So I have a picture of this because I'm like, what is that? It's like, okay, they told me what a LEEP is, but like, what actually is it? So here we can see it is literally like a little loop thing with a wire, and it will be used to essentially excise that part of the cervix, the part that's cancerous. So yeah, we got the LEEP, all that stuff, and then you can also do radiation chemo, because it is cancer. Okay. Anything else I want to put is that just keep in mind that vaginal like blood spotting is normal post-op, so it's expected for you to have a little bit of blood like spotting, and they should abstain from sex for 3 weeks or so. Sweet. Cool. All right, we're almost done. We just got endometrial cancer and then hysterectomy as a whole left, but I believe it's not too bad. So we'll probably finish a little bit early, which is great. Okay. So then you have your endometrial cancer, and I will again post that picture. So you can see here how the cancer is, again, this is where your cervical cancer would be where my mouse is, and then your endometrial cancer is going to happen actually inside of like the uterus area here. And it's going to come with different risk factors and stuff that kind of set it apart. So what are those? ERT as in estrogen replacement therapy. So if someone is getting, if like a woman is getting ERT, what might that kind of go with? Like, why would they be getting ERT? It's something we talked about on Friday. So we set HRT, ERT, same thing. Because in this case, they're getting estrogen. Yeah, nulliparity. So I'll let you guys ponder on what I just asked. Nulliparity meaning never given birth. Yeah, so someone that's doing menopause, or some not doing menopause, rather, they have menopause, um, that might be getting ERT. See, obesity is, I believe, again, another one of the possible causes. Okay, so we got a few other ones. Diabetes, smoking, hypertension, I believe those are all there. And then we said ages. It kind of goes with the fact that someone that might be getting this is someone that is menopause, so that menopause range a little bit more than the menopause age, menopause range, but somewhere along the line. So that's something that you can do. I think someone mentioned, let me just go back through all the answers. BC as in BC, the BRCA is like the hereditary. And then see, Rosemary mentioned the early menarche or late menopause. Let me double check on that. And then who else? Birth control. Yeah, so both of those are also. So early menarche and late menopause are also risk factors. Birth control, so the use of your birth control, I would imagine so, because your oral contraceptives are also gonna be, although in this case, a lot of the people here are probably not on birth control because they're already hit menopause age. But technically, um, this contains estrogen, so this is um, another thing that could cause it. Okay, so that sounds good. What are some risks, not risk factors, sorry, signs and symptoms? Big uterus, at discharge, and abdominal pain. Actually, I looked this one up and it looks like it depends on if it's combined with estrogen plus progesterone. And I think the progesterone actually um, makes this one not a risk factor. So this one, yes, this one, no, from what I just looked up. Just gonna take that one out for now. Yeah, so you'll have abdominal pain, lower back pelvic pain. Yeah, someone mentioned enlarged uterus, so yes. And something I will mention is that it can be asymptomatic in early staging, and then these two are late signs. And then when it comes to this discharge, it can be very specifically like a postmenopausal bleeding or bloody discharge specifically. Okay, so this is something to keep in mind. So that vaginal bleeding um, outside of like when someone's menopausal or outside of period, menstruation, the time when someone would be bleeding from their menstruation can be a sign that they have some sort of um, cancer, either the endometrial or even the cervical cancer. They both have the potential to have vaginal bleeding. But um, yeah, let's see what else. Okay, and then for diagnostics. So we're just gonna, and we talked about biopsies are number one. So an endometrial biopsy is gonna be your main thing here. And then what about your management? We're almost done here. Management for cancer, and then what can we do if we just cannot control what's going on in that area. Yeah, we're gonna do a total abdominal hysterectomy. And yeah, we can do radiation chemo. Most likely in the opposite order. So early on, we'll try radiation, chemotherapy if it gets a little bit worse, and then the hysterectomy if we can't manage it. Okay. Then finally, we can talk about hysterectomy. So what is some pre-op care that we want to do with hysterectomy? True. Probably all the stuff you guys can expect from pre-op stuff. So antibiotics before, DVT prophylaxis, so stockings, SCDs, whatever. What about some hysterectomy specific stuff? Type and cross. Sure, we can do patient education on post-op. It's kind of like a standard thing for the pre-op care. So that includes, yes, all your post-op stuff like turn cough, deep breathe, IS. We'll talk more, we'll write that down for the post-op. There's like maybe two that I'm thinking about here for pre-op that's like specific to hysterectomy. Yeah, so we can put that here then. Right now, we're still a little bit on the pre-op, so there's like a few things that I'm thinking about here. So we're gonna remove someone's um, uterus. Yeah, we want to make sure there's not a baby like in there, so like a pregnancy test. And then there's one more thing. This one's done to help the doctor, or the surgeon rather, reach the uterus. So it's to reach the uterus and involves the bladder. Not quite. So something they can do is they can do,
Put a Foley in.
yeah, they're gonna put a Foley catheter in specifically to depressurize the area, so that depressurize like the bladder area, just so that so that you're like having a full bladder doesn't get in the way, essentially. And then it's kind of like a FC as in Foley catheter. That's the Foley catheter. So this is the shorthand for it. FC is the shorthand for it. Could be a Foley, it could be an intermittent cath, but that's kind of the idea. So it's kind of like the opposite thought process. If you guys know for an ultrasound of the pelvis, they'll make you drink a lot of water because having a full bladder makes it easier to visualize. So it's kind of like the opposite idea where they don't want the bladder to get in the way, so they get rid of the urine. Does that make sense? Okay, so now we can move on now to the post-op. So Anne already mentioned that monitor for bleeding, although small amounts are normal, but just make sure they're not hemorrhaging. And if we're gonna have bleeding risk, I don't think they emphasize it too much in 220, but two large bore IVs in case of hemorrhaging. So some education there. You guys mentioned vital signs. Of course, we're gonna do vital signs. We're gonna do a lot of your like typical post-op stuff. So um, whatever you can think of, typical post-op. So like IS, early ambulation, all that stuff. Turn, cough, deep breathe. Oh, all this other stuff, like all your typical post-op interventions and stuff, vital signs. Um, the Foley catheter can be kept in order to keep reducing the bladder pressure so that it's not pushing down on the um, I guess the ex-uterus region on the region because it could interfere with healing rather. How long can be kept in this situation? That's a question I do not know the answer to, but I will look it up for you. Usually they try to get rid of Foley catheters as soon as possible. In this case, maybe like a day or two, but I'll go look it up. Yeah, actually, when I looked it up, it said typically removed between 24 to 48 hours post-op. So say about 1 to 2 days. Yes, so no sex, I believe is one of these actually. Let me double check. And do you guys know what two large bore IVs mean? Yeah, so 18 or 20 gauge because we need them to be that big so that blood can be given because otherwise the catheter is too small and the blood can burst. The little red blood cells can burst and then you're both not giving them what they actually need, like the actual useful red blood cells, but you're technically would be giving them a bunch of potassium because when they burst, they release all their little stuff that's inside. So you might give them hyperkalemia on top of not really helping them with the actual bleeding part because you're lysing the cells. Uh, And someone said pads, I believe. Let me see. I'll give you credit. Who said it? Who said it? I think it was somewhere in the beginning, maybe. It was Anne. Okay, so Anne mentioned the pads. So yeah, so perineal pads, and they're like these big pads for bleeding and clots. And the thing to keep in mind with this is that it should be less than one saturated pad in 4 hours. So that's something to keep in mind. So we talked about the bleeding. So I'll probably put this here so that it's all together. Something else. Someone said no sex, so yeah, no sex for like a little bit. Doesn't have to be bolded here. Oops. Like around 6 to 8 weeks. See what else can be important here. All your other stuff, monitor infection. Bleeding is probably like your big thing. So your dehiscence stuff, hemorrhaging, assess for the pads, make sure that they're able to get blood. Typically with the hysterectomy, so education on hormonal changes, because not only are they losing their uterus, it's typically also having their ovaries, fallopian tubes removed. So that means they're gonna have changes with their estrogen. It's basically like going into early menopause, essentially. And obviously, you don't need birth control anymore because there's nowhere to go. Nothing, nothing there anymore. I think that's the most for everything here. Seems like we covered everything necessary there. DVT prophylaxis. Okay, any questions on this? I think we covered everything. Yeah, covered quite a lot. Any questions on anything we talked about? Anything on the first few weeks or the first few, sorry, the first few parts before for today's? What do we got? Ovarian cancer and vulvar cancer. We didn't really go over it. There's not really that much to go over. But if you guys want it, I'll just do this instead. I'll just kind of talk about it instead. So ovarian cancer, I don't think it's very heavily stressed on, but just in case, I'll just mention some things. So ovarian cancer is fast growing. Risk factors include over 40, family history, diabetes, previous breast cancer, and never having children. Treatment, radiation, chemo, your, your total abdominal hysterectomy. Signs and symptoms include abdominal bloating, pain or pressure in pelvic area, vaginal bleeding, and discharge. Change in bathroom habits, so it could be urinary or bowel. Or, yeah, that's pretty much all I have on it. And then your cis vulvar cancer. Also don't really have too much info on here. But what I do have is some risk factors, 50 to 70 years old, history of cervical cancer, HPV kind of has to kind of go somewhat with cervical cancer part, diabetes, hypertension, smoking, obesity, can be some risk factors. Signs and symptom can include itching, irritation, unhealing sore. So a sore that does not heal. If you guys remember your caution up mnemonic on the vulva. We're gonna obviously diagnose with biopsy, do like a laser, be laser removal, for pre-malignant, meaning before they're actually like fully too bad. Um, include this more like this. Try to let you, radiation can be done, and you can even do like an ectomy, so like like excision of it. That's pretty much all I have on it. Just like a quick and dirty. I don't think they're heavily stressed, but again, I can't say with confidence because I think they switch their questions every once in a while for tests and stuff. So whatever goes on, it could be different. If they emphasize this more in class, then feel free to look at it a bit more. But as always, I recommend going through questions. So um, this is quite a lot. Like even like for our outlines, it's not usually as long as this. It's just a very long chapter or a long section rather. We do have a lot of pictures here, but it still ended up being like 24 pages on here, which is quite a lot. But hopefully that's still a bigger summary, and hopefully the review is still good compared to going through just the PowerPoints and whatnot, because it's even longer. And hopefully the pictures help, because I think some of these pictures I found on my own, as opposed to what was put in the PowerPoint. So hopefully it helps kind of keep things in mind, especially this one right here. I like this picture. It's funny. Yeah. Anything else you guys need or questions on anything? I'll get you guys the PowerPoint or the PDF rather. Okay. This one's a little chunkier, taking a little bit longer to upload. There we go, finally. All right, there you guys go. I'll upload the video as soon as I possibly can. And then I plan next week, you guys have PVD and ortho. I think I'm gonna split it between PVD and ortho. It's Friday PVD, Sunday ortho. And I'm assuming the ortho one's not gonna be as long. It's probably gonna be a little bit shorter one. And I think a lot of ortho ends up being review, and you can kind of shorthand it to CMS, think about your acute compartment syndrome, signs and symptoms. And then week 8, I think I will do gallbladder, thyroid, or whichever one you guys have your quiz on the Friday. Sunday, I'll do the male GU. And then I'm gonna see if I can find a good time to do the neuro outline. Either Tuesday or Wednesday, so you guys can have that before the final. Because I know it sucks that they give you guys a lecture on Monday and then it's on the final immediately after. And it's long too. It's not even like a short one. Yep. Yeah, and then get used to neuro always being like the last thing. Neuro is the last section in 220, it's the last section in 232, it's the last section in 240. Although the good part about everything past 220 is that it's not happening on week 9. The lecture ends on week 8, which is a lot better and nowhere near as much content. But yeah, you guys are getting through the hardest bit of 220, which is I think I would say is like after midterm. where after midterm is I think where you like lose time to be able to do anything because everything is coming in all at once. And because you guys spent all that time studying for the midterm, you were probably behind on women's studies because what is like your lecture on the same day as your midterm. So this is kind of where you fall behind a bit and you have to play catch up. So I think that's for me was the hardest part of 220. But you guys are almost done. Just a few more weeks. You have a great Sunday too, Diane. Yeah, that's all I got for you guys for now.
Thank you so much.
Yep.
Hey Diego, can you hear me?
Yeah.
Okay. I have a quick question. I am working on the peripheral arterial disease worksheet,
Okay.
that's due tomorrow,
Okay.
but I can I share my document with you? I just want to make sure I'm on the right track.
Sure.
Okay, give me a second.
Let's see. Oh
Let me
yeah, I'll stop
share.
recording this at the